Well, hi everyone. I want to thank everyone for joining us today, especially to our panelists. My name is Kanisha Gala, and I'm the project owner handling our clinical panel series here at LARVOL. Today, we're going to be discussing GU abstracts that were presented at ASCO 2021. We have 3 abstracts in particular that we'll be discussing today. And I just want to get us started by introducing our wonderful panel. So as moderator, we have Dr. Kevin Nuff. He is the Chief of Hematology Oncology at Highland Hospital and also an Assistant Professor of Medicine at UCSF. Our panelists include Dr. Matthew Galsky, who is the Acting Chief for the Division of Hematology and Medical Oncology, also the Director of Genitourinary Medical Oncology, and also a Professor of Medicine at Icahn School of Medicine at Mount Sinai, and Dr. Ashish Kamat, who is an endowed professor of the Associate Cancer Center and a director of the Associate Cancer Center and president of the International Bladder Cancer Group at MD Anderson. So thank you so much to our panelists and moderator. With that, I'll hand it over to Dr. Nuff to get us started.
Hi, welcome everybody. Another interesting ASCO. This time we're covering 3 abstracts, although the general category is GU. It turns out all of these are in bladder cancer. But 3 very interesting abstracts. Dr. Galsky, can you start with Keynote 52 update, abstract 458?
Sure. So Keynote 52 is the trial of pembrolizumab as frontline treatment for patients with metastatic urothelial cancer who are considered ineligible to receive cisplatin-based chemotherapy. You'll remember that this trial led to the approval of pembrolizumab for this subset of patients. There's been some twists and turns in that story, which I'm sure will come up with the discussion. And here we have long-term follow-up of that cohort, really demonstrating durable responses in this patient population.
You've been using this regimen for a while. Have you been impressed with the results in your patients as well?
So when responses occur with immune checkpoint blockade, like we see in most solid tumors, those responses can be quite durable. So yes, we do have some patients like those that are censored out at 4 and 5 years on these survival curves. Certainly different than the responses that we used to see with carboplatin-based chemotherapy in this context.
Yeah, it's very interesting. Trying to predict who's going to respond to PD-1 inhibitor therapy. CPS and PD-1 percentage is not perfect. In lung cancer, we see that patients who smoke tend to have a better response. Has that been true in bladder cancer in your experience or in these studies?
That's been evaluated in bladder cancer, although the questionnaires using validated questionnaires to collect some history has been done in a very small number of studies, and so the analyses aren't as rigorous as has been done in lung cancer. Those that have been done haven't shown a clear association, but probably that story is not completely written based on the methodologies employed.
Sure. And in this case, the CPS score is dichotomized by less than 10 or greater than 10. And in lung cancer, we see some correlation between a very high PD response.
Sorry, Dr. Nuff.
We lost you in the.
Oh, I'm sorry. So in lung cancer, we try and predict who's going to respond to PD-1 therapy, and we think smoking is a good, robust marker. And then there's some correlation with the higher PD-1 level and response. This dichotomizes the PD-1 level. Do you think that there's any greater utility or greater granularity of PD-1 where you can predict who's going to respond to these agents or not?
So this cut point was selected based on prior studies with pembrolizumab. This cut point with this assay in this trial performed quite well. But of course, there have been some inconsistencies even with the same assay and a similar patient population in Keynote 361. And so, yes, the current FDA label is for patients who are cisplatin ineligible with high PD-L1 expression, or for patients who are chemotherapy ineligible. That is a good marker in this study, wasn't as good a marker in another study. How to reconcile those two studies is not entirely clear.
Right. So this is a 5-year update of a previous study, and the survival curves are impressive. Does it change your feeling about this regimen, or just sort of validate what you've been doing all along for the past couple of years?
It really reinforces to me that frontline treatment with single agent immune checkpoint blockade should still be a treatment option for patients who really want to pursue this treatment and not be treated with chemotherapy followed by maintenance immune checkpoint blockade. And there are those patients out there. And there are those patients who are quote unquote chemotherapy ineligible. And so
Right.
this really reinforces to me what we've been doing in clinical practice.
Sure. And in this trial, it seemed fairly well tolerated with not a lot of immune-related responses. Has that held up in the real world in your department as well? Or?
Yeah, I don't think that we see any difference in the frequencies of immune-related adverse events in this patient population versus others. And that may be of relevance because patients who are ineligible to receive cisplatin-based chemotherapy, of course, that's an arbitrary definition, but it
Right.
goes hand in hand with other comorbidities, which might make patients more vulnerable to toxicities. And so, yes, we don't see an increased risk for those side effects in this patient population.
Sure. And a practical matter, with reimbursement for this and such, some of the other trials use cisplatin, patients who decline cisplatin rather than cisplatin ineligible. Has that been a problem getting this medicine reimbursed if a patient just says, I don't want to risk the neuropathy or the ototoxicity of cisplatin?
That hasn't been a huge push. There hasn't been a huge pushback in that regard, although that doesn't come up so commonly, but once in a while it comes up.
Yeah. Well, I thought this trial was very reassuring, completes the thesis that was started a couple of years ago. The trial conclusion seems to be very well supported and it seems to be very well designed. Do you have any comments more about this particular study or how it might impact your management or other GU oncologist management?
I think the take-home message for me is that, a single agent that's reasonably well tolerated with a median duration of response of over 30 months, and in patients with high PD-L1 expression, a median duration of response that hasn't been reached yet.
Sure.
That just reinforces this is a different class of drug than the drugs that we've used in the past. And we're still learning out how to best use these medications to treat urothelial cancer in terms of the optimal disease state.
Right. Not on this abstract, but I'm curious, do you have some long-term survivors who have stopped at 24 months and are continuing to respond?
Absolutely. In fact, just had a discussion with a patient today in that scenario. So we've had a number of these patients who've had to stop treatment for treatment-related side effects, for whom the response has persisted even when the treatment has stopped.
Great. And have you been using carboplatin instead of cisplatin in some patients rather than go to PD-1 inhibitor? How do you make that decision? Because more patients are eligible for carbo than cisplatin.
Because now we have level 1 evidence with switch maintenance immune checkpoint blockade, carboplatin-based chemotherapy followed by immune checkpoint blockade, certainly a standard treatment option for patients who are quote unquote cisplatin ineligible. And so that's really the treatment that we lay out as a major treatment option for patients in this context, but certainly discuss the data regarding single agent immune checkpoint blockade as well, the risks versus benefits, and then it very much becomes a shared decision.
Great, that's great. All right, Dr. Kamat, could you please introduce the next abstract, 4517, multi-center single-arm phase 2 trial?
Sure, absolutely. Can you guys hear me? Because I was having a little trouble hearing you guys. You can hear me okay? Thumbs up? Great.
Yeah.
Okay. So the next abstract essentially deals with the neoadjuvant phase. And this is neoadjuvant atezo combined with gemcitabine and cisplatin in patients with muscle-invasive bladder cancer. This was from Jonathan Rosenberg and that group in New York, reporting on a multi-center single-arm phase 2 trial combining atezo and GC in a cohort of patients. And of course, we all look to correlate pathologic response with outcomes, but in this trial, with the short, results were essentially the pathologic response. You can see the summary over there. What we tend to look at generally is less than T2 or less than muscle invasive bladder cancer. And if we look at that as a surrogate endpoint in this trial, it actually met what we would consider historic benchmark. In fact, if you just compare it with historic numbers, it was better than what you would expect at 69%. And if you look at the patients that had node-positive disease or actually had metastatic disease prior to RC, that would be, the patients over there as 7 and 2, so about 23%. So that's a little sobering to keep in mind, but overall, a positive result showing signal when you combine IO therapy with atezo and GemCis.
Right. This is a phase 2 study. Is there a phase 3 study looking at GemCis with or without atezo that's being done?
Yeah, there are multiple studies that look at combining IO with standard of care, essentially, and of course, many of these are investigator initiated, but they're also sponsored.
Right.
Atezo and GemCis. I believe my co-panelist Matt is leading one of those. Aren't you, Matt?
So there's studies with GemCis plus or minus pembrolizumab and in muscle invasive bladder cancer, and then GemCis plus or minus durvalumab. I'm not aware of a GemCis atezo study, but certainly phase 3 is testing this concept.
So in the sense that this result is interesting, is it just encouraging to enroll patients in the phase 3 trials while we wait to see overall survival as an endpoint? Is it changing your practice in any other way?
I think so, yeah, because obviously, the goal of neoadjuvant therapy, obviously, if you define it as neoadjuvant therapy, it's to improve outcomes of patients that are undergoing surgery. But you're also looking for signals, essentially, that would help us inform, and we'll talk about this, I guess, in the next abstract, potential bladder sparing paradigms, or potentially combining these with radiation therapy and as radiosensitizing. But yes, if you're looking at the pure endpoint of will this help our patients, is it practice changing, will affect what I do? I think we do need to wait for the results of the phase 3 studies. I believe the atezo GemCis is a European study. The lead investigator is out of France. I forget who it is, but we should look at that, wait for that, as well as the keynote results.
Right. Well, PathCR is a strong surrogate for overall survival and cure in breast cancer. So out here in California, we have the iSpy trial looking at adaptive therapy to get to pathologic CR with different chemotherapy agents. In bladder cancer, I guess this is logical to combine a PD-1 inhibitor with cytotoxics in a neoadjuvant setting.
Yeah, and essentially, again, the whole paradigm has moved and evolved over time. It used to be that a lot of urologists were afraid to refer their patients for chemotherapy. And in fact, even today, you talk to a group of people, and the thought process is that the perioperative complications are higher with IO therapy, which we know is not true so long as you time the IO therapy and the chemotherapy recovery appropriately. So having studies such as these, that essentially, obviously, this is the PathCR, but just overall experience is increasing with use of IO therapy in the perioperative setting. Obviously, chemotherapy has been used for decades, and people should not be afraid of that anymore. And looking at signals such as the adverse events, et cetera, is the more experience we gain, the better it is. Right.
And so you both at your institutions have collaborative tumor boards with the urologists to decide how to treat these patients?
Yeah, I'm a urologist essentially, obviously, so on the surgical side, but our multidisciplinary conferences are truly multidisciplinary.
Right.
To be honest with you, we've been using IO therapy in a neoadjuvant fashion since 2007, when we did the first in human CTLA-4 study in patients undergoing radical cystectomy.
Right.
So there's not that much of a discussion that occurs at our MDCs, but when we have trials such as this, and we currently do have the keynote study here open and enrolling, it's clearly important that we discuss it as a group.
Right. And Dr. Galsky, at your institution, how do you interact with urologists to get patients neoadjuvant therapy in a timely fashion?
So we're a pretty tight group in terms of our communication, both on patient care and research. So we're constantly in communication, but we do have formal meetings to review patients as well and optimize, navigation and care pathways.
Right. Okay. let's go to the third and final abstract then. Dr. Kamat, if you could talk about this phase 2 trial of GemCis and Nivo in selective bladder sparing patients with muscle invasive cancer.
Yeah, no, absolutely. And this is a very exciting study. And obviously, these are preliminary results from this study, essentially. And we have the privilege of having Matt Galsky as the lead on this right here. So we can ask him a whole bunch of questions that are deeper than just the abstract. But what this was is a phase 2 trial of GemCis plus Nivo combined with selective bladder sparing in patients with muscle invasive bladder cancer. And what we see here on the screen is the outcome of the patients that actually had a clinical complete response. So in this trial, the patients essentially offered the ability to spare their bladder if they had a clinical complete response, which you can see here in 31 patients, as determined by appropriate imaging, cytology, and cystoscopy, et cetera. So a very robustly defined complete clinical response, which is something that we haven't really seen well annotated in clinical trials that look at this question. It's all over the place. Some people use imaging, some just use cystoscopy and cytology. And we know that imaging and cystoscopy by themselves, and even combined, is not 100% for sure. But the patients then were given the option of either undergoing a radical cystectomy, which the minority elected, and the majority of patients did elect to preserve their bladder. And you can see here that, yes, there were some recurrences, non-invasive and invasive, amongst the patients that elected to save their bladder. But this offered the patients a paradigm, and offers us a paradigm to study further. And there was also a good molecular correlate that was done in association with the study, looking at TMB and then the DDR markers. And there seems to be a hint that at least ERCC2 and a TMB would correlate. Now, clearly, longer follow-up is needed, and we await the results. But having Matt here, Dr. Galsky, we can pick his brains.
Yeah, no, this is fascinating. This is really, because I'm used to treating these patients with who want bladder sparing with chemoradiation with Dr. Schoenberg when he was at Hopkins, and this is a radiation-free option. Dr. Galsky, is the thought that the phase 3 trial there will be a phase 3 trial? How will you incorporate these results off trial now?
So I think we need more mature follow-up before feeling comfortable that this should be offered in the context of standard clinical care. Right. I think we need longer follow-up to make sure that these patients on the red bars here who have not experienced local recurrence and have an intact bladder remain that way for an extended duration of time. There are a couple of other studies going on nationally looking at variations on this theme. And so I think viewing all of those in context will help us feel comfortable whether or not this is a viable approach moving forward. I think the phase 3 study to ultimately test this is a difficult study to do. And if one can establish a rate of bladder intact disease-free survival that's high enough to make this a compelling option for some patients, because there are patients who really do not want local therapy regardless of appropriate counseling. I think if there's a high enough rate, then combining all these studies, I think that will increase our comfort in terms of integrating this paradigm into practice.
This study would have fallen under my radar as a general oncologist, so it's fascinating to hear about it. How long after the patient started their therapy did they have a repeat cystoscopy to be sure?
So four cycles of GemCis Nivo, and then immediately after that 4th cycle, repeat cystoscopy, repeat imaging.
Okay, but all these 31 patients better than anybody as the first author. Was there any sort of correlates that led you to who would be these red bars, which is a desired outcome?
In terms of have we identified any putative biomarkers? Is that the question?
PD-1, ERCC. Dr. Kamat just said, anything different about those patients who did so well than other patients who could?
So there are of course multiple ongoing analyses to try and define that. What the data that we have so far includes DNA sequencing on the baseline tumor specimens And so far, that's been correlated with achieving a clinical complete response, but not these time to event endpoints because the data is not mature enough. And so right now we know that having a high TMB or having a somatic mutation in the nucleotide excision repair gene ERCC2 is associated with a higher likelihood of achieving a clinical complete response. What we don't know if those same biomarkers will predict the patients here in the red versus those in the blue. And that's ultimately what we want to know.
Right. And another good thing here is all patients are still alive in follow-up, even if they had a local recurrence or required a cystectomy. So this trial is not something we can just bring to clinic right away, but I think it's highly provocative. We have an extra 10 minutes. You doctors speak a little quicker than than breast. Anything else that was interesting in this ASCO you want to bring up while we have the audience here?
Well, the one thing I do want to kind of highlight when it comes to this abstract and similar is we really need to get, and I know Dr. Galsky and colleagues do that, but in general I think we need to involve our patients and the patient advocates into the trial design of such trials, because the question that sometimes eludes us is what does the patient perceive as the true benefit? Clearly, patients don't want to lose their bladder, right? But
Right.
is it the frequent local recurrences that might be non-invasive? Are those as bothersome to the patient as we suspect or not? Because we don't look at non-invasive recurrences as a true endpoint. We only look at invasive recurrences. But sometimes when you talk to patients, they're like, well, no, I just don't want to have repeated cystoscopies and TURBTs. And so I think this was a very well-designed study with the imaging and the cystoscopy biopsy, all those endpoints.
Right.
But we don't often see that in the design of other studies. So I think kind of formalizing those sorts of endpoints and definitions and getting the buy-in from patients is critical. And I know, Matt and I are working on just such an endeavor currently to kind of standardize those endpoints. I think those are going to be very important to keep in mind.
Are you two utilizing any prospective quality of life metrics as you do these studies? I mean, there's a detriment, obviously, in quality of life for having a cystoscopy, but it's not huge compared to having a cystectomy or metastatic recurrence. Are you like checking that as you go along and quantifying that?
In most of the studies that we do, and I'll let Matt speak for his group, but we absolutely involve quality of life studies. And that's where we sometimes get surprising results. There's a prospective quality of life based study ongoing right now, which is funded by PCORI and with the help of Beacon, which is being run by John Gore and Angie Smith, essentially looking at a similar question of bladder sparing, but this is in patients who have BCG unresponsive disease and then elect to undergo radical cystectomy or not. And essentially we want to understand, is actually sparing the bladder improving the patient's quality of life? Because we have patients that undergo, radical cystectomy, and then you see them, winning golf tournaments and wrestling championships, and you see them all over the news. On the other hand, we have patients who are just, bogged down by repeated biopsies, TURBTs, et cetera. So on my side of the field, before we get to the metastatic arena, bladder sparing is very important, but we do definitely need to understand, from the patient perspective, are we, driving this endeavor and not considering what is actually important from the patient perspective?
Does that vary a lot from patient to patient, their like or dislike of those procedures?
Oh, it's very individualized. It's very personalized. It also depends on access to care. Folks that have to drive 3 hours to get a treatment that allows them to spare their bladder are more likely to tell me, please just get it out so I can get on with my life and not spend 6 hours every day coming back and forth just to get treatment every week.
Yeah, we've seen that, in breast cancer, women who are far away from radiation centers will opt for a mastectomy rather than go through lumpectomy and 6 weeks of driving back and forth. When you say you involve patient advocates in the design of trials, how did you actually do that? That seems like a logistical challenge.
In bladder cancer, we're fortunate. We have Beacon, which is the Bladder Cancer Advocacy Network, which is a very strong, robust patient advocate group, just as you have in breast cancer. And we've had patient advocates involved in the design of studies through multiple cooperative groups. Also, they sit obviously on our own internal IRBs and SITC, Society of Immunotherapy for Cancer, that I chair the Clinical Practice Guidelines Committee. We involve patients in there. So we do that, in the bladder cancer community. We are involving our patients in the design of these studies as much as we can. And obviously, we try to recommend to pharma-driven trial design panels to also do the same.
And you two are tertiary centers. How do you think information these abstracts can distribute to community centers and community-based oncologies?
Well, through webinars such as these.
Yeah.
I was just going to make one additional comment regarding the patient-reported outcomes and quality of life, because it really fits in well with something that Dr. Kamat brought up, which is that absolutely PRO should be integrated into our trials. I think there's still some need for understanding how to best utilize that information in terms of individualizing treatment decisions, in that if you look at the perfect example in the context of our discussion, which is the big bladder cancer chemoradiation study published in the New England Journal of Medicine, that really solidified the role of chemoradiation. Nicely done quality of life analyses prospectively integrated into that study. And the conclusion was that there's no difference in quality of life, baseline versus after finishing treatment in long term.
Right.
But that's analyses pooling all the patients, which is how these analyses are typically done. But the investigators also reported individualized outcomes, paired sort of pre, during, post. And what you see there is a more nuanced story. You see that a third of patients had an improvement in quality of life. A third of patients had a deterioration in quality of life, and then the rest were somewhere in between. And so when we say that, our treatments don't impair quality of life, well, they do for some patients, other patients do better. And so it's hard to integrate that at a population level and apply it to individualized treatment decisions, of course, because you don't know, just like you don't know if a patient's going to respond to treatment or not, you don't know if that treatment's going to cause a deterioration in quality of life or not.
Yeah. Well, genitourinary oncology has a long tradition of embracing quality of life in studies because of all the work done with prostate cancer and quality of life from treatments there. I think, of the oncology specialties, they may be ahead of some of the others in terms of looking at patient-reported outcomes and quality of life.
Yeah, unfortunately, we don't have a biomarker for quality of life. That would be that would be too easy.
Psychosocial oncology is a very challenging field, and it's very much, as you said, related to each patient and their own perceptions, and part of the art of medicine of sitting and talking to a patient and trying to understand things from their perspective. Well, I think we've done a great job with these three abstracts. Anything else anybody wants to say before we close?
I just want to thank you for doing such a wonderful job moderating this.
Oh, thank you. It's a pleasure.
Thank you.
Yeah.
Great. And I want to also say thank you to the three of you. Thanks, Dr. Nuff, Dr. Galsky, and Dr. Kamat, for joining us today. To our audience, I just want to let you know that this discussion will be available for replay on LARVOL's YouTube channel. And stay tuned for future discussions such as these, as we try to dissect the abstracts presented at conferences and try to get at the clinical application of those abstracts. So thank you again to our panel. I know I learned a lot. I'm sure our audience would say the exact same thing. Thanks again.
Thank you.
Thank you.
Thanks, guys. Bye.